Hi, my name is Connie Kaklanus and you're watching the video on the management of constant exotropias. Now, because this patient has an exotropia all of the time, this means that in free space, the patient is either going to be experiencing diplopia or they will be experiencing single vision through the sensory adaptation of having, for instance, suppression. It is therefore your duty as an orthoptist to determine the potential for binocular functions, and we do this with tests such as the synoptical examination or perhaps using a test such as the Prism Subjective. So in performing these tests, we will determine whether the treatment that we prescribe is likely to provide us with either a functional outcome, the patient has BSV with treatment or post-treatment, or whether the patient will end up with a cosmetic outcome whereby the patient's eyes look straighter, but there is no binocular single vision. Now, we'll go through the GOODS acronym again and look at the treatment options that we have for patients with a constant exotropia. However, before we do that, I want to highlight that you need to consider if there's any underlying condition that needs to be treated before we look at that GOODS acronym. Now, you always do this with every patient, regardless of the type of deviation that's present. However, I mention it here in particular because we've also got the secondary exotropias here, which is generally due to pathology. So as an example, if a patient has a congenital cataract which has obstructed binocular single vision, the patient has thereby developed an exotropia, then we need to consider removing the cataract before we progress to managing the deviation present. Okay, let's now go through that GOODS acronym. The first consideration we make is whether we're going to prescribe glasses or not. So we will determine this pending the refraction, and you will prescribe according to the principles of prescribing for a patient with an exodeviation. In relation to occlusion, this is only required if the patient is young and has developed amblyopia. In terms of orthoptics, now this is where it gets a little bit tricky for these patients in that we have a constant exodeviation, which means that we can't build binocular functions whilst the patient has a constant deviation. We need to have some BSV at some point in time to be able to exercise binocular functions. So often orthoptics are prescribed post-operatively when the surgeon has achieved either a residual exo or a consecutive exo that's smaller in size, and we can now train the patient to take control of that deviation, assuming that they have the potential for binocular single vision, which you will have needed to have determined prior to surgery. You can utilise orthoptics preoperatively if you, for instance, bring the patient fovea to fovea with a Fresnel. So you would prescribe a Fresnel as an example, and then prescribe orthoptics to build on those binocular functions. But this would only be the case if you had a small deviation that you thought that you could teach the patient to control without surgery. More often it's the case that you need surgery to bring that exotropia to a size that the patient can now control with their binocular functions. In terms of the type of orthoptic exercises one would prescribe, well, again, you'd be looking at that group of exercises which works on convergence or fusional convergence or positive relative fusional convergence so that you can manage that exotropia. Let's now move on to our options in relation to drugs and surgical intervention. With drugs, Botox is an option. Botox is more often used when post-operatively you have a patient who has a consecutive or a residual XT, but there is potential for BSV, but the patient is diplopic and hasn't actually fused the two images. So in this instance, you've got a small angle post-op deviation. It's exo, and what we do is we inject the extraocular muscle to regain BSV, also the patient can regain BSV, in the hope that as that Botox wears off, the patient holds on and locks on to having BSV. If they've regained binocular single vision with a Botox, you could actually also give them orthoptic exercises during this period to build their binocular functions so that they can maintain control once the Botox has worn off. Now, in terms of surgery of a constant deviation, as per usual, depending on whether you have a near distance disparity, you would determine whether you're going to do unilateral or bilateral surgery on the basis of that PCT result. Now, in relation to the amount of surgery, this is generally dependent on whether the patient is going to have a functional or a cosmetic outcome. With a cosmetic outcome, you want to give the patient overcorrection and make them ET if you can, i.e. if they're not going to have post-op diplopia when you move the image to nasal retina. So if they can suppress that image, which means they're young enough to suppress it or they have an old suppression scotoma on that side of the retina, then overcorrection is the best option because they don't have BSV. There's nothing that's going to hold them in that position over time, and so generally there will be an exodrift over time as the patient ages. So with the functional treatment, in this case, because the patient is going to have BSV post-operatively, then a full correction should be okay because they're going to be able to control the deviation and therefore they should be able to cope with an exodrift later on in life if it occurs. However, you could also aim for a slight overcorrection as well if that's desirable. Okay, before I conclude this video, I want to touch on the topic of which extraocular muscles do we operate on when a patient has had a history of surgical intervention. So let's say, for example, we have a patient who comes to our clinic and they have a consecutive exotropia. So there used to be an ESO, they now have an XT, and the surgery that they had is a recession of the lateral rectus of the right eye and a resection of the medial rectus of the right eye. And when we see them, they've got a right consecutive exotropia. Let's say it's basic in nature, and we want to do unilateral surgery, recess, resect. Usually we would perform the surgery on the right eye. However, the medial rectus and the lateral rectus have already been operated on previously. So in this instance, it is best that you move over to the other eye and actually perform a recession of the lateral rectus here and a resection of the medial rectus here, even though it is a right XT that you are documenting in your notes. And the reason we do this is because the outcome is more predictable, the post-op outcome is more predictable if you operate on a muscle that's never been operated on. The other thing I want to mention to you is that, say for instance, this patient used to have a divergence excess exotropia, and at that point in time, the two lateral recti were recessed. And now you see them and they've got a residual constant exotropia and it's basic in nature. It's the same size near and far. The ideal for this patient would be to do unilateral surgery, a recess resect procedure. But both lateral recti have been operated on. So in this instance, you would consider operating on the two medial recti, so resecting the two medial recti, rather than doing a medial rectus resection and repeating a recession of the lateral rectus or doing more of a recession of the lateral rectus. Again, it's because we will have more predictable results if we operate on a muscle that's never been operated on. And yes, whilst you may be concerned that by operating on the two medial recti, there's going to be a greater effect on the amount of surgery at near, it's probably also worth noting at this point that there is a lack of evidence in the literature that supports whether to do unilateral or bilateral surgery when there is near distance disparity. Despite this, I want you to utilise that principle in managing your patients, but you can let go of that principle when you have a patient who's been operated on previously. Now what becomes more important than the near distance disparity is having or operating on a muscle that's not been operated on before. Okay, that brings us to the conclusion of this video. Thank you for watching.